Bismillahirrahmanirrahim. My name is Dr. Aziz Qadir and I would like to tell you about merits of NIV use in COVID-19 patients. As we all know that initially most people were reluctant to use NIV in COVID-19 patients because of the fear of infection to healthcare workers, because NIV is an aerosol generating procedure. But now as the pandemic has unfolded, most of the societies around the world have now recommended that NIV should be used, but with some extra precautions and some modifications in the management of acute hypoxemic respiratory failure in the patients of COVID-19. Historically, there have been two types of mechanical ventilation or artificial ventilation. In the past, negative pressure ventilation was in vogue mainly in 60s, 70s and early part of 80s, but now mostly in almost all the centers of the world in ICUs, positive pressure ventilation is used. And we can divide positive pressure ventilation into invasive mechanical ventilation and non-invasive mechanical ventilation, which uses positive airway pressure to ventilate the patients. What is the difference between CPAP and BiPAP or BiPAP? CPAP is continuous positive airway pressure, which means that pressure during inspiration and expiration is similar. How does CPAP help to the patient? It has four types of effects. Number one, it acts as a splint, keeping the airways open. Number two, it increases alveolar recruitment, which is the most important physiological effect that we want to achieve in hypoxemic patients. Number three, due to positive airway pressure, it decreases the physiological dead space. Number four, it decreases threshold load, leading to increased triggering or facilitating the triggering. So all these effects help in improving oxygenation. So what are the uses of CPAP? It is used in acute hypoxemic respiratory failure, that is type 1 respiratory failure. It is used in OSA, which is obstructive sleep apnea, and it is used in acute cardiogenic pulmonary edema due to its effects on hemodynamics and heart and lung interaction. BiPAP is bilevel positive airway pressure, which means that there will be IPAB during inspiration and EPAP during expiration. The difference between IPAP and EPAP is pressure support. The more the pressure support, more will be tidal volume, which means that it is used for ventilation, that is to decrease carbon dioxide levels. So the use of BiPAP is in conditions where you want to increase ventilation and decrease the work of breathing, means offloading the respiratory muscles of the patients. So it is used in the cases where there is type 2 respiratory failure due to any cause. So if we want to reduce hypoxemia, to improve hypoxemia, we will use CPAP. BiPAP is not needed for the sole purpose of achieving better oxygen levels. The indications for CPAP are: number one, OSA; number two, acute hypoxemic respiratory failure; number three is acute cardiogenic pulmonary edema. And indication for BiPAP is type 2 respiratory failure due to any cause. Most common indication is COPD with type 2 respiratory failure, and other causes of respiratory failure with increased carbon dioxide may be due to central nervous system, a neuromuscular disease, a diaphragmatic paralysis due to any cause. And what are the contraindications? Anything which hampers the application of mask, for example, anatomical defect, upper airway defects, or patient's refusal, a patient's intolerance, psychiatric patient, a patient with vomiting, a patient with excessive secretions, a patient with very low GCS, for example, GCS below 11, and these are all the contraindications to, some are absolute and some are relative contraindications to NIV. What are the advantages of NIV over invasive mechanical ventilation? Of course, it is non-invasive, so you do not have to pass endotracheal tube. and there is no chance of developing BiPAP as a result of endotracheal intubation. So there is no need of sedation during the use of NIV, and patient can be fed through NG or orally. And the most important advantage is that patient can communicate with the doctors, while a patient on invasive mechanical ventilation cannot communicate. Disadvantages are that the respiratory mechanics take time to improve, so it is a slow process. The improvement comes very slowly, and it needs trained staff. It is time consuming, and you should ideally place patients on NAV in the setting of HDU or ICU, where the staff is usually trained. Due to the mask, there can be air leaks, so you will have to take care of air leaks as well, because it will decrease the effectiveness of NIV. And secondly, a patient can develop sudden hypoxemia with the accidental removal of the mask. So you should be vigilant all the time, especially the irritable patients do not remove their masks during the treatment. With prolonged use of the mask interface, skin necrosis can occur. So you have to take care of skin necrosis. In some patients, you have to use silicone dressings, specially made gels, special interfaces, so that the skin necrosis can be prevented. Disadvantage is that you do not have access to the airway. So if you want to take cultures of from trachea or from below, from the lower airways, you want to clear the secretions, you want to do suction, you cannot do with NIV. But overall, it has proven to be very effective treatment. As an example, I will give you an example that in acute exacerbation of COPD, it is said that 80% of cases you can prevent invasive mechanical ventilation. Talk about use of NIV in the setting of COVID-19 pandemic. Because there is risk of aerosol generation during the use of NIV, we should be careful while using NIV when we use interfaces where the masks are vented. Vented masks are those masks which have exhalation ports. So there will be aerosol generation, during the time the patient exhales, the aerosols will be spread into the room. So in these settings, you will have to use extra precautions like level 3 PP. Ideally, you should use interfaces which have non-vented masks, which means there are no exhalation ports. As you know that we can use NIV on the ventilators as well as on CPAP and BiPAP units. On the ventilators, because ventilators are closed system, the circuits are separate for inspiration and separate for expiration. There are two circuits connecting to the interface, and the masks are usually non-vented, so they are safe for as far as the COVID-19 is concerned. Similarly, for BiPAP or CPAP units, ideally you should use an interface with a non-vented mask and double circuit. That means a closed system. NHS recommends NIV only when you use a closed system with non-vented masks. But here, as we do not have enough non-vented masks, we do not have enough ventilators, we have BiPAP units as well. So we take extra precautions if we use when we use NIV on patients through BiPAP or CPAP units with vented masks. We'll come to how you will set up an CPAP or BiPAP on a patient. First of all, you will have to see the indications for CPAP and BiPAP. You will have to choose a proper interface. Ideally, for first 24 hours, you should choose a mask, a full face mask, or an oronasal mask, because it will prevent leak from the mouth, because initially the patient may be a mouth breather, may be apprehensive. If you use a nasal mask, there will be leak through the mouth. So initially you should use a full face mask or a oronasal mask, and then you will set IPAP and EPAP separately. Initially you should set a lower pressure setting so that the patient can acclimatize and tolerate it. For example, for BiPAP setting, you can start with EPAP of 4 and IPAP of 12, which means a pressure support of 8. And after a few minutes, you should allow the patient to touch the mask or to hold the mask initially so that the patient's fears are allayed. As the patient acclimatizes with the mask, you can slowly and gradually increase the pressure settings, but keeping in view that you should not disturb the pressure support. For example, you can increase EPAP by 2 to 5 centimeters. Similarly, whenever you increase EPAP, you will have to increase IPAP as well to keep the pressure support intact. You will increase, for example, from 4 you can go to 5, 6, 7, 8, and from IPAP of 12 you can go to 13, 14, 15, 16, according to the patient's response. And within half to 1 hour you can reach up to your desired settings. For a normal built person, a desired setting can be, for example, IPAP of 15 and EPAP of 5, which means a pressure support of 10. And for patients who are obese, or those patients who were already using NIV at home, for example, for OSA, for OHS, for them you can start with higher settings of pressures. For example, 515, you can start with 515, a 616, a 618, keeping in view the pressure support needed for the removal of carbon dioxide. For oxygenation, to achieve optimal oxygenation, you will have to increase EPAP. But remember, whenever you increase EPAP, you will have to increase IPAP by the same amount. And for the purpose of washing out carbon dioxide, you will have to increase the pressure support to increase tidal volume so that there is increased ventilation and decreased work of breathing. People often ask that what can be the maximum settings of IPAP and EPAP. For EPAP or CPAP, they are interchangeable. You can go up to 10 or 12. You should not ideally go beyond 12. The ideal is 10. You should not go beyond 10, and thin, lean or normally built person, for obese you can go up to 12. And for IPAP, you can go up to as beyond 25 to a maximum of 30, but up to 25 should be optimum, because you know that lower esophageal sphincter pressure is 25 centimeter of water. So if you cross that point, there will be increased chances of gastric distension and aspiration. So you should ideal settings for a normal built person is 5/15, and for an obese person is 6/18 or 8/22. 3 types of modes on BiPAP, but I will tell you about the modes in the end. First, I will tell you that another setting which you have to do is backup rate. Backup rate is the rate at which the ventilator will deliver breaths when the patient will not trigger in the ST mode of BiPAP. So backup rate should be 2 to 3 breaths lower than the patient's actual breath rate. And you will have to set TI, which is inspiratory time. Inspiratory time is usually 1/3 of the total respiratory cycle. For example, if you set inspiratory time of 1.5, for example, if you set backup rate of 15 breaths per minute, which means for each breath you have 4 seconds, and 1/3 of inspiratory time means 1.3 to 1.5 should be TI. So you will set TI, and it can be changed according to CO2 level. And now I will tell you about one fact, that there are factors which decrease the effectiveness of NIV. You don't have to waste too much time, but you will have to assess the patient actively. And then there are few factors which decrease the effectiveness. For example, if the patient is near respiratory arrest, there will be no use of NIV. If the pH is less than 7.25, or if the SOFA score is too high, Apache 2 score is too high, or if patient's GCS is less than 11, all these factors limit the effectiveness of NIV. How will you judge that NIV is effective on a patient? There are two ways, subjective and objective. Subjectively, you can see that patient is improving, there is increased compliance with the device, patient is more comfortable, the respiratory rates has significantly decreased. And objectively, you can do ABGs to assess the level of PaO2 and PaCO2. Three types of NIV modes, BiPAP modes. Number one is spontaneous mode, number two is ST or spontaneous timed mode, number three is AVAPs, which is average volume assured pressure support mode, which is a special mode. It is not present in all machines, it is only present in the latest BiPAP units. Now I will tell you pictorially how these modes are different from each other. From spontaneous mode means that patient have to initiate breath. The BiPAP unit will only augment that breath, support that breath. So it is equivalent to assisted modes on ventilation. The spontaneous timed mode means that patient can initiate breaths, but after a certain backup rate, the ventilator will also initiate a breath. So it is called spontaneous timed mode. It is equivalent to assist controlled mode of mechanical ventilation. So S or spontaneous mode means that patient will initiate breaths and the BiPAP unit or ventilator will assist those breaths to deliver a set pressure. For example, you set IPAB and EPAB, a set IPAB and a set EPAB. So these S means spontaneous breaths. The initial deflection below, it indicates patient's effort, the negative intrathoracic pressure which patient creates to initiate a breath. And then there is a set volume of pressure, which is IPAP, is given to the patient, and then this is inspiration, this is inspiratory plateau, and this is expiration, and this is IPAP level which you have set. So there will be spontaneous breath according to the patient's own breath rate. There is no backup rate setting on spontaneous mode. While in ST mode, which is spontaneous timed mode, in this mode you can see that you set a set EPAP and an IPAP. S are spontaneous breaths which the patient initiates, while T are the mechanical breaths which the machine initiates, a timed breath. You can see after initial spontaneous breath there is a negative deflection at the start, which indicates that patient has initiated the breath. There is a set IPAP and then expiration. After a set backup rate, when the machine senses after set backup rate and expiratory time, when the machine senses the patient has not initiated a breath, according to the backup rate, the machine will initiate the breath, which is timed breath, you can see here, and it gives a set volume of IPAP and then inspiration, expiration, and then patient initiates his own breath. You can see a negative deflection. It is called spontaneous breath. So this is spontaneous timed mode of non-invasive ventilation. It depends on Backup rate, the timed breath, a mechanical breath depends on the backup rate you have set and the respiratory time that you have set. Then the third and most modern mode of NIV is AVAPS. As I have told you, it is average volume assured pressure support. It means that you set certain parameters and the machine automatically adjusts to give you results according to your set parameters. It will give average tidal volume to the patient regardless of patient's effort. So it is an advanced mode. It is not present on all the units. It is present in the most latest and costly units of BiPAP machines. You will have to set a few parameters. You will set a maximum IPAB, a minimum IPAB, a set EPAP, a tidal volume, and respiratory rate, which is a backup rate. And for example, you can set an IPAP maximum of 25, minimum of 20, EPAP of 8, 10, 6 as per your needs, a tidal volume 450, 500 as per the patient's predicted body weight, and respiratory rate should be less than patient's own respiratory rate to prevent the lung injury due to asynchrony. So the respiratory rate should ideally be around 14, 15, 16, maybe lower. So these are the ventilation modes of NIV. I will tell you hemodynamic effects of positive pressure ventilation. Just briefly, what are the heart-lung interaction with positive pressure ventilation? Positive pressure ventilation decreases venous return because of positive pressure, because it increases intrathoracic pressure, it increases peripheral vascular resistance. So if the patient in volume depleted patients, there is decreased venous return, which means there is decreased preload, it can adversely affect hemodynamics and patient cardiac output and blood pressure will fall. While in patients who are overfilled, like in patients of cardiogenic pulmonary edema, it has beneficial effects by reducing the preload because of decreased venous return to the heart and by assisting cardiac contractility. Because of positive pressure, there is increased afterload, so pulmonary edema can be reduced with this effect of non-invasive ventilation. Sometimes because of increased PEP, we reduce cardiac output and we are seeing only at SaO2, but because of decreased cardiac output, there is tissue hypoxia. So the net effect of PEP, which on one hand increases oxygenation and on the other hand decreases blood pressure, is nullified. So you should be careful about application of PEP. To tell you that you should not fear this NIV, it is very effective, it is very important, and it can be safely used even in the situation of COVID-19. Just take extra precautions like level 3 PPE and use it in all patients who are having very low PF ratio, like PF ratio of less than 250 or less than 200, and who are hypoxemic, whose oxygen level doesn't rise despite 100% oxygen with non-rebreathing mask. For example, if a patient comes to you with very low oxygen saturation and tachypnea, you give him oxygen with non-rebreathing mask, his SATs are still less than the 90%, you should use NIV in this patient setting. In the end, please remember these 7 tips. Number 1, please decide early for the use of NIV before it is too late. Number 2, decide escalation plan and sealing of respiratory support beforehand with the consent of attendants and write it in black and white whether you want to escalate to invasive mechanical ventilation if it is needed, or you want to end up at the level of NIV. Number 3, start with lower pressures always so that patients can get used to it and tolerate it better. Number 4, use rise time as low as possible, like 1, and use ramp feature in those patients who are difficult patients and who do not tolerate NIV at the outset. Number 5, use nasal cannula under the mask in those patients in which you fear that accidental removal of mask may occur, and at least patient will get some oxygen when he removes the mask accidentally. Number 6, you should give the patient monitored breaks during which he can eat, he can talk, he can massage his facial skin, and he can talk. Number 7, you can use catheters, nasogastric tube and diapers so that patient do not have to move frequently and can get NIV as long as possible. Now I want to talk about another mask which is called PEP mask, positive end expiratory pressure mask, which I say is a poor man's CPAP. It is very cheap. It is about a price of 1/10 to 1/20th of a CPAP machine, because it doesn't have a positive pressure device, but it has a PEP valve at the expiratory port with pressures ranging from 5 to 20 centimeters of water. It gives some PEP at the end of expiration, and patient oxygenation usually improves unless the patient is too fragile or too serious to require a CPAP. Thank you.